liver transplantation session. Firstly, I would like to thank the organizing committee members for kind invitation. The second, especially, I would like to remind the catastrophic Turkey earthquake, especially in our area, southeast of Turkey, because yesterday we had a very, very big two severe earthquake and a lot of the deaths due to earthquake. And I would like to start.
Yeah, it's my privilege to address to this distinguished floor here, and I'd like to welcome again our friends from the United States, the ASLD faculty, especially Ray is here. I cannot count how many times, but we always learn too much from him, and also other colleagues, distinguished friends, and also, of course, the Turkish Association for the Study of Liver for organizing this very important meeting. For this liver transplant session, the first speak will be given by Professor Pierre Golam, the liver meeting update on liver transplantation. Professor Golam.
Thank you very much. So obviously transplant's always a fairly substantial part of the liver meeting, and this was no exception. I think before we start talking about all of this, I need to preface this by saying that transplantation, certainly in the United States, and I suspect worldwide, is progressing at a pace that has made it almost unrecognizable compared to 4 or 5 years ago. This is primarily due to the advent of new organ preservation technologies like normothermic machine perfusion and regional perfusion. And this will not discuss these in any detail. I know Dr. Kim will talk a little bit about this, so stay tuned, because that's obviously an important complement to what I'm going to say. I'd like to break this down into practical topics that any transplanter in the room would be very familiar with. And the first sort of section of this presentation will revolve around pre-transplant issues. If you think about your typical patient that you consider for candidacy for liver transplantation, there are two issues, and I would suspect in everywhere around the world, those two issues are the dominant barriers slash facilitators of whether the patient ends up getting a transplant or not. The first is psychosocial assessment. That always takes an enormous amount of time. And the second is cardiac risk assessment. And this abstract specifically addresses the issue of cardiac risk assessment and how it is fraught with some challenges that we may be able to improve on. This opening slide just shows you a typical, at least US-based algorithm for how we assess someone from the time we determine that they may be a liver transplant candidate to the time we list them. And you don't need to look too much at the details here other than to tell you that there are two central nodes that govern this. The first is dobutamine stress echo, which is a pharmacological stress test that basically allows you to assess whether there are areas of ischemias in the heart. And the second is CT with coronary flow, which is essentially, if you want to think about it, a functional imaging of coronary vessels that allows you to tell whether the patient has coronary artery disease or not. And these have become fairly standard fare in our ability to assess patients non-invasively. This does not mean that many patients don't end up needing a cardiac cath. We do this all the time. But this is a more realistic way of assessing this in the majority of patients. So this abstract, which is abstract 13, specifically looks at those two modalities. This is from the University of Michigan, and basically it grades your ability to complete CT coronary arteries and dobutamine stress echo. And if you've ever ordered these on a transplant patient, these should not look unfamiliar. So what is the biggest impediment to a successful dobutamine stress echo? That's right, your patient is on a non-cardioselective beta blocker. They failed to reach their target heart rate, And the cardiologist says, I could not really conclusively tell you whether your patient has jeopardized ischemia or not. This happens in about 14% of cases, and quite honestly, in my assessment, this is low. At our shop, it happens in over 20% of patients. I'm sorry, this happens in 30% of patients, and in our shop is about the same. Coronary flow is a much more objective test. It requires a cardiac imager to read it, and even this is actually unsatisfactory in 14% of patients. So even with your best efforts to actually obtain these non-invasive tests at a quality center, you still have a very substantial percentage of patients that don't end up successfully completing them. Now, if one were to shoot for specificity, the best test to order would probably be dobutamine stress echo. But that is actually not the focus here. You'll notice that for specificity numbers, you have pretty high numbers for DSC. What you would like is a test that has a high negative predictive value, a very good test to rule out. And that appears to be a combination of CCTA plus flow rate. That tends to have a much higher sensitivity and superior performance versus dobutamine stress echo, which has a higher specificity. And according to these ROC curves, you can see that neither of them are perfect, but certainly CCTA tends to perform better than DSC. And according to the authors of the abstract, CCTA should be the preferred primary non-invasive modality for the pre-liver transplant coronary artery disease risk assessment. I would be lying if I said that at our shop we do this. We typically do both, but in many places people are strained for resources, and if you were to pick one, that would probably be the one you would pick. The next is another critical issue, which is frailty, right? If you think about your patients, if your surgeon walks them on the ward and you say, I would like you to consider Mr. X for liver transplant, and Mr. X cannot be actually getting themselves out of bed, they cannot transfer to a commode, they cannot walk a few steps to the bathroom, your surgeon is likely not going to be terribly excited about transplanting them. Well, there are objective ways of codifying this. And the two most common ones we use are the 6-minute walk test. This is literally asking someone to walk at their own pace for 6 minutes, and depending on how far they go, less than 250 meters or more than 350 meters, you can determine more or less whether they are frail or robust. And the other one, of course, is a frailty index, which is a complex set of measures that you add in a table, and it gives you a frailty index. This includes standing up from a seated position, repetitive movements, and also assessing grip strength. So this basically looks at these two techniques to get a better sense of whether one is superior to the other. And to cut a long story short, there really is no difference by frailty category for index versus 6-minute walk test, no difference in ICU days, no difference in 30-day readmissions. Graft loss, interestingly, for reasons I didn't clearly understand, seems to be higher in the frailty index group versus the 6-minute walk group, perhaps a reason to use that preferentially, and post-liver transplant death were quite similar. There was also a tendency to have a longer length of stay with the frailty test in the frail patients and in the pre-frail patients versus the robust patients. These are areas under the curve that basically model 6-minute walk test with other confounders. And as you can see, the areas under the curve for 6-minute walk test versus liver frailty index are very similar. So I'm not saying that there is any conclusive strategy here as to whether you use one or the other. I would say definitely you want to make an assessment using one or the other and be aware of the limitations of that strategy. The next topic I'd like to cover, which was also extensively talked about at the liver meeting, is donor and allocation issues. So I think, Ray, you would be keenly aware and much more well-positioned to talk about this than I ever will be. But MELD 3.0 is certainly an effort to improve access and equity in organ allocation. This added 2 variables, female sex and serum albumin. It lowered the ceiling for serum albumin from 4 to 3, and the inclusion of 2 interaction items between albumin and creatinine and between bilirubin and sodium. There is some literature that suggests that MELD 3.0 did reclassify some patients to a higher MELD tier, which is of course what we want, right? And if you look at an analysis typically of the listed patients, you see that there are fewer waitlist deaths compared to the MELD sodium era, which was what happened before MELD 3.0. This became the law of the land in July 2023, so now we use this as the standard operating procedure for allocating organs. Now, this is all great, but has this actually worked specifically to address sex disparities, which was one of the big issues with the old system? I'll remind you that because women have a smaller muscle mass, they tend to have a lower creatinine, and therefore increments in creatinine are not adequately reflected when they develop kidney disease, or not necessarily captured in the formula. And if you look at the OPTN is the organism that oversees organ allocation in the US. You look at the time frame between 2/2020 and 9/2024, so you're bridging that period of time before and after the new rule came into place. It appears that this seems to be working. So the primary outcomes which were received for one of the top 5 liver organ offers and probability of undergoing diseased donor liver transplantation, these both substantially increased in women compared to men. And in fact, numerically speaking, the top 5 offer rate increased by 16% for women. And if you look at absolute person days increase, that's about plus 5.1 per 1,000 person years. Transplant rate increased by 18%, right? So that's all good, plus 0.6 per 1,000 person years. But by June 2024, if you actually looked at all of this, it had actually returned to where it was before. Why did this happen? Because, of course, one of the factors that a surgeon factors in to transplant a patient is not just their MELD 3.0, it's the very practical aspect of whether someone's abdominal cavity is big enough to accommodate a liver or not. So body size, somehow, unintentionally, I'm sure, basically normalized this, and the effect of sex seemed to be now attenuated, adjusting for height and weight. And so that is a disparity that, according to this abstract, continues to exist despite MELD 3.0, simply because the organs available oftentimes do not match the donor's body habits. The other very important question that we struggle with in transplant is the validity of creatinine, right? Is creatinine really the best way to measure kidney function? We know that creatinine is dependent on many variables, muscle mass being one, and others. Might cystatin C be a better test for this? And this is a collaborative effort from all over the world, but primarily driven by Argentina and the University of Cordoba in Spain, looking at a set of patients that were initially studied in Argentina and subsequently validated by a cohort of patients from the University of California, San Francisco. And so the idea here is, can we swap creatinine for cystatin C, and might we then be able to have a better discrimination of the patients who are high acuity, high risk, and therefore get them to transplant appropriately at the time when they need it? They looked at 90-day mortality, and during that time, there were 61 deaths in the validation group. That's about 4.7% of patients. In Argentina, the initial group had 44 deaths, which is 5.16%. And at UCSF, there were 17 deaths for 3.3%. They basically used 3 different systems. One is MELD sodium, sort of the older version of MELD 3.0. The other is MELD 3.0, and the third is something called GEMMA AI. GEMMA stands for Gender Equity Software, which basically is a machine learning algorithm that factors in many issues and tries to account for low body habitus, serum creatinine by sex, and actually adjust this to give a more objective outcome. There were 5 risk tiers. There was a patient reclassification assessment, so they're actually looking to see whether they reclassified patients based on these different tests that they would have classified in a lower risk category before. And what this shows is that overall, cystatin C swapping basically resulted in what we call a new reclassification index that is greater with cystatin C versus creatinine. So the overall NRI, as they call it, was 10.1 plus 10.1%, meaning they classified patients in a different category if you used MELD sodium. 3.0 basically went up to 14%, and this JEMMA AI score, which again is not really used in any legislation that I'm aware of, actually brought it up to 15.6%. If you look at these 3 tables here, you'll notice that at the very low end of your MELD score, the lower line, you're actually going to reclassify very few patients. And at the very, very high end, you're going to reclassify no patients, because if your MELD score is 40, you're not getting any advantage from actually having a change in your creatinine. And if your MELD score is very, very low, you're probably unlikely to get that changed either. It's mostly patients that sit in the middle that actually have an impact on reclassification that this cystatin C swap may impact. So to sum up, this does not improve the discrimination when substituted 1-for-1, but it identifies high-risk patients missed by serum creatinine, particularly if these patients are sicker, they're frailer, they're female, or they're more likely to die. So something to think about in the future. This is really not likely a situation that you encounter frequently in Turkey or most parts of the world, and I only include it as an exercise in thinking about how a rule change creates unintended consequences downstream that can be disproportionate to what the rule was intended to do. So this basically looks at patients who get a combination of a liver and a heart transplant. This is not a common occurrence, as you can imagine. For example, I looked, and in 2023, only 76 patients received a combined heart-liver transplant in the United States. But they realized that this was very difficult to do. You have to cut somebody from their neck to their pubic area, and so you have to do this major surgery, and it becomes very problematic healing, and you are not getting patients actually transplanted at a relatively low MELD when they needed it. So in 2018, the OPTN multi-organ committee decided that patients who were listed for a combined heart-liver transplant would bypass everybody else. They would even bypass patients who had a MELD greater than 35. And this is actually looking not so much at what happened to those patients, it's looking at all the other patients who were turned down or bypassed as a result of this new rule, right? So that's basically the high acuity patient, anybody greater than a MELD of 35, before 2018 versus after 2018, that was bypassed by this new rule. And in fact, I told you that anywhere between 40 to 73 patients only every year get transplanted, but look at how many patients were bypassed. 2,014 patients were bypassed. These were high MELD patients that actually ended up not getting a transplant when they did a MELD run, right? And so in the first era, before the rule came into place, there was no difference in survival between patients who had patients that they analyzed. But if they looked at the bypass candidates, these candidates turned out to have a lower survival. So when someone passes on you because you're being bypassed for the heart-liver transplant patient, you end up probably not getting transplanted at the same frequency as the other person, and your outcome is worse. Now, this is actually shown nicely in the intention to treat survival curves, where the bypassed arm in blue clearly has lower survival over time, out to 360 days. This was, of course, not done intentionally or maliciously. This was only done because they wanted to facilitate transplant for heart liver, and in fact, probably had a deleterious consequence on a much greater number of patients. The next topic we're going to talk about a little bit is HCC and transplant. As you know, there is a tremendous interest, which we've discussed in our fantastic session earlier this morning, in leveraging the ability of using immune checkpoint inhibitors as a way to potentially downstage HCC so that it can be transplantable. This is something we routinely do in practice now. We have a standard protocol where we have a washout period. At our shop, for example, we use a TKI during this washout period until we get the patient transplanted, and that seems to work well for us. There's a number of studies that suggest that this is a fruitful avenue, and this is a paper that looks, or an abstract that looks at over 70 centers who conducted this worldwide. They basically looked at the outcome, and they looked at the outcome of recurrence, and they looked at survival and acute rejection, and they did a number of statistical analyses to look at these outcomes. So they managed to find 408 patients. 60% of these were from China. Mean age was 55, majority were male. 75% of these patients had Child-Pugh-A. Most had relatively modest tumor diameter. I have a little bit of a problem with that, but because, of course, many of the patients we transplant have larger tumor diameters. About 21% of these patients had macrovascular invasion, again, reiterating the fact that if you have branch portal vein invasion, this no longer means you can never get a transplant. There certainly is increasingly optimism with regards to that. About 57% of patients had undergone local regional therapy before, and some had undergone local regional therapy after ICI. You might ask why that happened. Well, in China, if you get transarterial if you get a cycle of chemotherapy, you usually get a cycle of transarterial chemoembolization in an unselected manner. I learned this recently when I traveled to China. Whether you actually have a visible lesion or not, they just infuse beads in your right and left artery, and they think that that somehow helps reduce recurrence after a definitive therapy. So that's why you actually have 34% of patients who underwent LRT after an ICI. This basically breaks down the patients by how many were within Milan, that's about 23%, and how many ended up progressing to the point where they received a liver transplant. And most of these patients were on monotherapy with a PD-1 or a PD-L1. The vast majority of them got nivolumab. A small percentage got pembrolizumab, and a number of them got products that are only available in China, including camrelizumab, which is not FDA approved in the EU or the US. So 19%, pretty high, right? So rejection these days, acute cellular rejection, not common. 19% is pretty high, right? 6-7% is about the norm, ended up rejecting. 26% recurred and 21% died. This does not look fantastic, right? We want outcomes to be better than this. I will also very much highlight the fact that this is not exactly a study with clear inclusion-exclusion criteria. This is really an amalgama of patients from around the world that they're studying. Having said that, if you actually look at patients within Milan, especially if they had an AFP less than 100, their outcomes were actually much better. Their recurrence-free survival was greater, and their prognosis was much better than the overall group of patients. So if you look at risk factors for rejection, the two risk factors were older age. We know that older patients tend to reject more, so that's not surprising. The other one was an immune checkpoint inhibitor washout per 30 days period. So the shorter the washout period from the time the patient receives an immune checkpoint inhibitor to the time they get transplanted, the more likely they are to reject, right? That makes sense because that means they were exposed to a PD-L1 or a PD-1 recently, or I don't think any patients got a CTLA-4, but that certainly would increase their risk pretty dramatically. So that one does not surprise me in any way. By the way, at our transplant program, our standard washout period is 60 days. We do not transplant patients if we've given them immunotherapy for at least 60 days. And in the meantime, we can keep them on a TKI, usually lenvatinib, and that usually works out well for us. Clearly, when you shorten that period of time, you pay a price in terms of potential rejection. HCC recurrence, obviously, there were a number of factors that they adjusted for, and not surprisingly, your log AFP at transplant was a big factor, right? If your AFP is high at transplant, you're more likely to recur. And of course, being within Milan criteria actually have cut in half the likelihood that you will recur. Overall survival also was adjusted for a number of factors, and the two factors that impacted it, of course, the most were HCC recurrence, that shortens your life almost immediately, and severe rejection, which somewhat surprised me because we can usually get patients through rejection without too many problems, but that appeared to be another factor that played into it. So the key takeaways here was that acute rejection is common, 1 in 5 patients, certainly much higher than what we would expect in clinical practice. Those within Milan and those who have low AFP have the best outcome, nothing new there. And this is just a different perspective. This is more of a stateside perspective from the Mayo Clinic and other centers around the world. This is just to show you that these somewhat pessimistic numbers do not seem to reflect the consensus at this point. This is somewhat hard to treat, but I will just highlight the important points here. This is also a group of about 20 liver transplant patients, 60% male, mostly Caucasians. If you actually look at the number of patients, who got acute cellular rejection, it was actually 1.5%, so a much lower number than the other patients. And if you look at the number of patients that died in this large cohort of patients, it was 16 deaths, 11 were cancer-related. These were mostly patients who had advanced disease, and the others had sepsis, ARDS, and unfortunately, one of them had ICI pneumonitis, which is a terrible disease that if you get it, you are very likely to die. So what this sort of differing view, which is mostly a US perspective, suggests is that immune checkpoint inhibitor is actually treatment with careful immunosuppression. If you use an ICI early on and you refer the patient early, there may be more room for the transplant center to actually act in a way that would enable the patient to potentially receive treatment without a lot of problems. And it is not really entirely clear what the optimal period of time that basically one would have to wash out before they get a transplant is, although as I mentioned, the consensus based on the evidence we have right now seems to be around 60 days. And I think I'm going to stop here, and I don't know if we have time for questions.
Thank you, Professor Golan, for a very comprehensive debrief. So in order to buy some time, let's leave the questions to the end and skip to the next presentation.
The second presentation by Jessica Mellinger. She will talk about controversies in early liver transplantation for alcoholic hepatitis.
All right. Great, thank you. So we'll just kind of jump right in. So when I think about controversies in this setting, I think sort of setting the stage with what's gone on in the past 10 to 15 years, I think as everybody knows, this really got opened up with the seminal pilot trial in the New England Journal in 2011 that was published by the Franco-Belgian group and Philippe Mathurin that showed in a highly selected group of patients with very strict criteria, you could select patients who had been recently drinking, coming into the hospital essentially, transplant them and get good initial 1 to 2 year outcomes with respect to mortality. Now that group of patients in that pilot trial was extremely conservatively selected, right? So that 2% of the patients that they evaluated ultimately went on to transplant. That's appropriate for a pilot trial. So I think one of the key features and one of the key areas that we're looking at now that this has gone on and kind of really been a paradigm shift in how we do liver transplant, at least in the United States, for patients who have ALD, is how do we select these patients? What outcomes are we looking at as the first section? Who's high risk? We use this term a lot, right? Oh, they're high risk. What does that mean and why does it matter? And then looking at post-transplant management and some of the issues there as well will be sort of the three things I'll look at. So this is just to kind of give you a perspective, at least again from the US, that essentially after that 2011 paper, we really started to see centers increasingly open up their lists to patients with short sobriety, less than 6 months of abstinence. Prior to that, very much the standard of care for decades had been 6 months or more of abstinence, and you wouldn't even really get a look in at transplant unless you had that. Now, the advantage to that is that it does allow for some time to see if the liver will improve. As you recall from one of my earlier talks, we do see improvement, we do see recompensation over time, but it takes time. And so figuring out which of those patients are going to be improving or not is key. So that first question, are we doing this right? I think this is kind of where we've been stuck. We've been stuck with this topic in how are we selecting these patients and kind of really thinking carefully about selection. So when I think about this, there's some certain ethical principles that we think about with respect to transplant selection in general that are applicable here. And really a lot of this boils down to principles of justice. So urgency, equity, are we being fair? And then utility. So urgency is who is sickest, who's gonna die first. That's MELD, right? So MELD is telling us who's gonna die of liver disease the fastest. We wanna get those patients through to transplant. So this has been an area of controversy recently. Dr. Trotter published an editorial about this a couple of years ago, that because these patients are so sick, they have MELDs in the high 30s, 40s often when they're in the hospital, and they're often otherwise pretty healthy because they're young. There's a perception by some that they are kind of taking organs, that they're so sick that they're being prioritized in a way that might be unfair and violating our principles of equity, perhaps unfair to the rest of the patients who are on the list or who've been waiting. The other principle of justice that I think is interesting that we haven't really talked about much with this is this principle of utility. So utility is a little different than urgency. Utility is what happens after the transplant, right? It's what we just talked about with HCC, right? Milan criteria is all about who's going to recur post-transplant. It has nothing to do with your urgency. It's about how you do afterward. But we don't do that with other things, right? We don't have a utility criterion for PSC. We don't have a utility criterion for PBC. We do not look at whether or not PSC patients recur and need retransplant as a reason to list or not list. So I think this area of utility, we often talk about it, right? When we're talking about who's going to relapse, who's going to go back to drinking alcohol. We're thinking about it with respect to this population, but we have not codified it in a way that shows us how we can actually measure post-transplant outcomes, or if we should measure post-transplant outcomes and use it as an allocation decision in this population. So again, these are the Dallas criteria that were published in 2019. These are somewhat evidence-based, but largely expert opinion and consensus opinion on features that should be used or could be used to select patients. In the United States, as I said, over 90% of centers are transplanting patients with less than 6 months of abstinence. There's really no guidance from national liver transplant societies about how to do this or what criteria one has to use. It's a little bit of the Wild West. So you can do it like this or you cannot do it like this. Because it is competitive in the US, transplant centers compete within different regions. One of the criticisms during the Dallas conference was if you open up to short sobriety transplant, it will create an arms race. If one center starts to transplant patients with minimal evaluation, right? Maybe they don't have really strict criteria for psychosocial assessment. Maybe they don't follow this, but they say, okay, you're good, we're gonna transplant you. Then that means other centers have to compete with that, and it kind of lowers the bar for selection. So how do we implement these? Should we implement these? What is some of the data to support these different criteria? And more of that has come out. So this notion of the first decompensation. So this is often one of the most controversial topics, and I know in my own center, this is the one where people are kind of looking at the patient saying, well, they kind of had jaundice 6 months ago, but they didn't have ascites and they didn't have encephalopathy. They didn't have any decompensation symptoms. Like, does that count? Does that mean we can't list them right now? It's a little difficult to tell. So this becomes a kind of a controversial topic of how to figure this out. Was a patient told that they had advanced liver disease or not if they didn't have decompensation symptoms? And this was some data that came out a couple of years ago that actually did show that patients who had been transplanted who had drank over a decompensation, so they decompensated but they kept drinking or went back to alcohol use, actually did have worse outcomes post-transplant. And they also went back to increased harmful use more frequently than patients for whom it was their first decompensation. So there is some data to support, again, that maybe patients who have drank over a decompensation might do worse afterward. Why is this? So I think this is a metric of how severe their alcohol use disorder is. So if somebody has severe symptoms of their liver disease, yellow, vomited blood, was in the unit, all of that kind of stuff, and they keep drinking, they have a more severe alcohol use disorder. It's going to be tougher to treat. So I think that's what we're seeing here. I'm going to go back to this data that we saw earlier from the liver meeting. And this is, again, where they kind of looked at the risk of post-transplant survival, likelihood of mortality post-transplant, and also likelihood of post-transplant harmful alcohol use. And you can see that for some of these Dallas criteria, some of them they don't matter, and then some of them they do. So the prior liver decompensation, you were 3 times as likely to die post-transplant. And you also had substantially greater post-transplant alcohol use. And again, more alcohol rehab attempts led to more harmful alcohol use, led to more difficult outcomes because it's a harder to treat thing. It's a more severe alcohol use measure. So is it time for a Dallas 2.0? I think it is. I think it's time we have to come back, we have to reconvene and look at this data again, almost 10 years now, maybe 8 years now from the time that we did this first conference, and see where we're at. Because if we're applying criteria to people that don't matter or that don't predict anything, then maybe we shouldn't have that criteria. We shouldn't be excluding people from transplant for criteria that actually don't have a clinical impact. I wanted to talk about corticosteroids briefly because that is also part of Dallas, that they have failed or have been ineligible for corticosteroids. I don't use a lot of steroids, I'll be honest. I don't find them to be that effective, and often my patients have a lot of contraindications to it. So it isn't heavily used in my own practice. Actually, Mark Thurse, who wrote the Stop AH trial, also said he barely uses it, and he wrote the major New England Journal paper on prednisolone. But this was a retrospective study by Dr. Arab, who's now at VCU, that looked at whether or not there was kind of an optimal window for steroids. And essentially in this international study, he found that there was, that essentially it was this kind of meld, anywhere from 25 up to about 40 might be your optimal time frame. You start getting outside of that and it may be less effective. You're hitting futility as you get into the higher levels of meld, largely because people's kidneys are failing if you're in that high level of a meld, and it simply is not going to be effective. As you go up in your ACLF grades, the effectiveness of corticosteroids begins to drop. And then now you're just exposing your patients to side effects, infections, bleeding, and then also psychiatric side effects. So corticosteroids increase risk of relapse. They are a very psychoactive drug. So if we have patients on high-dose corticosteroids, we are putting them at increased risk of relapse. And if you'll recall from the last talk I gave, that increased risk of relapse portends directly to their mortality if they've survived an episode of this ALD. So these are not benign medications, and they have to be on them for a month, right? If their allele score passes at 7 days, they're going to be on that for 28 days. That is not a benign medication. And so I do not prescribe these for patients unless I know that it's going to benefit them, their allele score is appropriate, and I'm going to be able to see them again. And so many of my patients, I don't know that they're going to come back to my clinic. They may not see doctors frequently. So in that case, I won't prescribe it because I worry I'm going to do more harm than good. This issue of improvement, I think, is really critical as well. This was a great paper that Ramon Battier did a number of years ago In the first 7 days, they looked at hospitalized patients who did not get corticosteroids, and they tracked bilirubin improvement. And what they found was that for patients who were so-called fast fallers, who had a more rapid decline in bilirubin in those first few days in the hospital, they didn't need the corticosteroids. They didn't have a response. They were not better off for getting it. So I think when we think about steroids in alcoholic hepatitis and pre-transplant, are you failing steroids? It's not like antibiotics and sepsis. There is no door to steroid time. Okay? You can take your time, see how they're doing, and if they're improving, you may not even need to give it, right? The vast majority of the studies of steroids gave the steroids under that 7 days. So I question whether in these studies, that some of which have shown the benefit of steroids, if they really had a benefit or not, or if these were patients that were going to get better anyway, even without the steroid. You've got some studies that are giving steroids 2 days after they show up into the hospital, right? Maybe a substantial portion didn't even need them. So the second major challenge is to look at who's high risk. So we often use this terminology when we're talking about these patients. They're high risk, right? They're high risk. We know that post-transplant relapse does impact the graft. You do see increased graft loss if you have longer, heavier alcohol use. The red bar here are patients who had severe relapse, and you can see that some of them die within 5 years and get recurrent cirrhosis in that time frame. That's fast. So I use this to talk to my patients about post-transplant alcohol use. If they are under the impression that they're going to get another 30 years on that new liver, I got to disabuse them of that notion, because that is not the case if they go back to heavy alcohol use. They can get recurrent cirrhosis and die and have graft failure in under 5 years if they go back to heavy drinking. So it's very real, but predictors of relapse is tough. Again, as I talked about in my earlier session, predicting relapse is not an exact science, and it's very challenging to do. Some of the best predictors that we have miss maybe 1 in 4, sometimes as many as half, won't be well predicted by these relapse predictors. And that's because there's a lot of different predictors of post-transplant relapse to alcohol use. How long did you have sobriety? The 6 months is not really a good cut point. Right? 6 months doesn't tell me anything more about that person's post-transplant risk of relapse than 5 or 7 months. More abstinence is better, but again, 6 isn't some magic number. So having prior alcohol treatment or lacking prior alcohol treatment actually predicts a lower risk of relapse, right? Being treatment naive, which is a little counterintuitive, actually predicts a lower risk of relapse. But again, that's because if you fail treatment repeatedly, you have a more severe alcohol use disorder, so it may be a little bit tougher to treat. And pay attention to this early post-transplant period under a year here, okay? More pain, less energy, more fatigue, more stress, other substance use. These things can portend relapse in that early pre-transplant period. So that's stuff for us to watch for, right? Are my patients in pain? Are they needing to talk to somebody? Are they having more anxiety? We can prevent the relapse early if we watch for it in this sub-1 year period. Insight is another feature that I think is getting more attention. This was a paper that we published in our research group looking at insight. So we talk about this all the time. I don't know if you guys talk about this in your transplant committees, but we say, this person has insight into their alcohol use, or they don't have insight. They understand or they don't understand the features of alcohol use and its impact. But we don't really know what we're talking about when we say that. We use the term, but we haven't defined it. It's poorly validated in the liver disease population. And a lot of times, in the literature at least, we're talking about different concepts here in terms of what this even means. So it's a really high-stakes decision that we are making about whether or not we should transplant someone, and we're doing it with terminology that we have not defined well and that we have not validated in this patient population. So this is current work that we're doing at Henry Ford to get on top of this and validate this. I'm going to skip over some of these models because we've kind of talked about them. So how do we optimize this psychosocial evaluation? So it requires time. Psychosocial evaluations, social work evaluations often require time and repeated assessments. We don't always have that time in these short sobriety patients. Time is the CT scan for our psychiatry and psychology colleagues to see what happens. If a patient is comatose and intubated, we do not accept them for transfer to our institution for transplant evaluation for this indication, because we have to be able to talk to the patient, not to their family, not to anybody around them, but to the patient to see what is their insight, what is their commitment to sobriety, how are they thinking about this. And again, this is just to show that there's a lot more that goes into an assessment of whether or not someone is psychosocially ready to do this and to care for the liver afterward than just a 6-month sobriety. So there's not a lot of hard psychiatric contraindications to transplant. So this should not be intended to be interpreted as, oh, if they don't pass this list, they don't get a transplant. It's more, we want to be able to care for these patients afterwards, so let's find out what's going on now. Let's make sure there aren't any hard contraindications. A recent suicide attempt, right? Like they tried to kill themselves the week before they got to the hospital. They have a psychosis that is uncontrolled. These types of things, we wouldn't go forward with a transplant for a patient immediately. But everything else we can work on. Everything else we can pretty much work on and get them through. And so this is kind of my little provocative statement. So they're going to relapse. So what? So what? They relapse after transplant. We can treat it. Why are we so fixated on whether or not somebody is high risk for relapse? Aren't all these people high risk for relapse, right? They lost their liver because of heavy alcohol use. Again, these are often young patients. They are not going to make it through the rest of their lives often without taking another drink. They just may not tell us about it. So when we think about high risk, what exactly are we talking about? Are we talking about relapse to alcohol use? Are we talking about relapse to another substance use, which will increase their risk of relapse to alcohol? Are we talking about non-adherence to medical treatment? Are we talking about non-adherence to alcohol treatment? It's all of the above, but we don't define it. We just say they're high risk. And then the final challenge is really the post-transplant management. So this is, in my opinion, the best prospective study of comparing early liver transplant, short sobriety to standard liver transplant. And this was the Quick Trans trial that was done again in France and Belgium. So their primary outcome here was actually relapse. And it was a non-inferiority trial. So is it just as good as standard LT? And it wasn't quite. It didn't quite meet their primary outcome. So patients who had short sobriety, less than 6 months, actually did have a slightly higher risk of relapse, but their mortality was identical, right? Mortality didn't change. So they relapsed, but they still lived. There was no difference in that mortality. So again, relapse, a little provocative, so what, right? Let's just treat it. Let's get in and treat these patients. So post-transplant drinking, this is retrospective data from the Accelerate cohort. You can see patterns in post-transplant drinking for these patients. And if they drink early and heavy, they have worse outcomes at 3 and 5 years. But look at that 1-year outcome. They all survived, right? So again, if you're in a competitive transplant environment and you see that 1-year outcome and that's what you're judged on, these patients are going to look pretty good, right? And you may not even want to do much of a pre-transplant evaluation of their psychosocial metrics. But if we care about what happens to our patients long term, 3 years, 5 years down the road, then we really do want to find this type of drinking and get on top of it. Younger women actually fared a little bit worse, and this again was US data that looked at post-transplant outcomes in the 5-year range. So again, 1 year they do pretty good, but at 5 years, the biggest difference that we saw was in young women under age 40. So about 1 in 4 of those people died, of those young women, and it was because of alcohol. So transplanted for ALD, young women under 40, dying to a far greater degree than any other category, and it was of alcohol. So something is happening here. I'm not sure if it's a selection issue. I'm not sure if it's a post-transplant management issue. Either way, I do think we need to really get better post-transplant management and post-transplant safety nets for these patients and really look carefully. I showed this earlier, my favorite slide, that getting back to abstinence after relapse basically gave you the same exact mortality, same exact survival as never having relapsed at all. So to me, again, this mandates integrated management post-transplant. And again, as we talked about, integrated care, especially for liver transplant patients, works. It reduces mortality, right? There's not a lot else that we can do for these ALD patients besides transplant them and then help them stop drinking to keep them alive long term. This is an example of post-transplant kind of, I think, very innovative thinking that was happening at Penn. So they created what was called the Total Recovery LT program. So they started what was essentially an intensive outpatient program for their high-risk post-transplant short sobriety patients. And they put them through this, a 12-week program. They had 84% of their patients enroll. It was very patient-centered, and so it was designed by the patients as well as their system. And they had 42 patients in it. The people who completed it, only 10% relapsed, whereas the non-completers, we saw 40% relapse. So this is the kind of thing that I think we need to see more of in the post-transplant space. Innovative kind of wraparound integrated care for these patients that actually does work to reduce that risk of relapse and keep them alive. And we've seen these before. I showed you these in my last talk, but just to emphasize the fact that we need to be moving downstream into the post-transplant management phase and get away a little bit more from this kind of monomaniacal focus on, are they high risk for relapse? How can we assess whether or not they're going to relapse? Accept that some people are going to relapse and work on the post-transplant management, the detection, and the return to abstinence for these patients. I'll finish there. Thanks.
Thank you, Meninges. Thanks, because I will not any question from hall because of time limitation.
So the next speaker will be Professor Ekim, and we would like to hear from him the recent lessons in liver allocation in the US. Professor Ekim.
Good afternoon. I'm glad that everybody's staying awake. Okay, so I am going to talk about the recent trends in liver transplant, and as Dr. Golem referred to, I will talk about DCD and machine perfusion. Are there transplant surgeons? Any surgeons? Okay, so you're familiar with this, but a lot of hepatologists I don't suspect are attuned to this topic. So it's an important innovation in transplant, so I'm going to talk about that. And then I have a counter response to what Dr. Golem said about MEL 3.0. So for the hepatologist, which of the following is most strongly associated with DCD graft survival? Cold ischemic time, is that most important? Donor warm ischemic time, that's important. Recipient warm ischemic time, or total warm ischemic time? Okay. And others, sorry to bother you. So the cold ischemic time is the right answer, and this is the number of transplants done by donor type in the US. And you can see that in 2012, the country of the US had about 6,000, a little less than 6,000 transplant. And the record stops in 2023 at 10,000. And these are mostly deceased donors. The top line is living donor. And there's a significant increase, 40% increase over 10 years. Our population didn't grow that much. And the majority is the regular donation after brain death. But there is the middle part that has increased significantly is the DCD part, donation after circulatory death. And since 2023, that line took off further. So by some measure, I'm told that about 40% of all transplants are DCDs. So if you track this 40%, we're way higher than 10,000 today. So ischemic times, this is the answer. So donor warm ischemic time is when the liver is in the donor, and if the circulation stops, the liver starts deteriorating, right? So you want that short. And then you have a cold ischemic time, the liver under ice, and then you go to the recipient, and until you have all the vessels connected, the liver is suffering warm ischemic time. So cold ischemic time is what determines graft survival, most importantly. warm ischemic time is a critical factor for bile duct damage. So solution for cold ischemic time is NMP, and the donor warm ischemic time is NRP, and I'll tell you what they are. But before that, donation after brain death, DBD, is the regular mechanism that you think about. So death is declared based on the loss of brain function. And because of that, the circulatory function continues while the brain is dead. So liver receives oxygen and everything else until the procurement team goes in and disconnects the liver. So the warm ischemic time is minimal or none, and the risk of ischemic injury is small. DCD, on the other hand, is circulatory death. So the death is declared when the heart stops. And that's when the circulation to the liver stops. And from that moment on, the liver starts to decay. And the warm ischemic time is between the circulatory arrest and the organ is recovered, and therefore there's higher risk of ischemic injury. So if you don't think about this is a DCD process. You have to get a very clear consent from the family what's going on. These are patients with a devastating neurologic injury or some other cardiopulmonary disease that there is no hope for this person to recover once life support system is removed. So this person is in the ICU and there's no hope of recovery. And we decided to treat the withdrawal support. Those are the DCD candidates. Then the patient is moved to typically the operating room, and under that controlled environment, life support is withdrawn. And we wait until the patient heart stops. And then there's a mandatory, and then the death is declared, and then there's a mandatory no-touch interval to make sure that the person is really passed. And then there's a mad dash to get the organ out. So that transition of care from ICU team to procurement team, and the procurement occurs very, very quickly, and then organs taken out and preserved. So donor ischemic time at the heart stops, and until the organ is out, the organ is warm and ischemic. And that is the process called super rapid recovery, and it's measured in 2 to 5 minutes. So the surgeons here know that once the heart stops and everything is declared, you have to get the liver out in 5 minutes. You can think about how rushed procedure that is. You have to cut the abdomen, get into the liver, and get the blood vessels tied off and cut. You get it out in 5 minutes. That's incredible. So that's the difficulty with DCD surgery. So innovation there was normothermic regional perfusion. So when the heart stops, you basically support the liver with heart-lung machine. So localized air exchanger, you provide oxygen to the liver, but just to the liver. It doesn't, if you supply oxygen to everybody, every organ in the body, then the person would wake up and be alive, right? So that's not the purpose. So the person is dead, heart stopped, and the organ is perfused from that point on. That gives the surgeons to have a controlled opportunity to get the liver out in a very, very safe fashion. So that eliminates warm ischemic time in the donor. That's number one innovation for DCD, normothermic regional perfusion. So the result is here. Again, warm ischemic time is bad for bile duct. So IC is ischemic cholangiopathy. NRP versus super rapid recovery, there's no ischemic damage with NRP. Anastomach stricture, much lower with NRP versus SRR. Other outcomes, early allograft dysfunction. You can see peak AST and ALT much lower with the NRP, and the length of stay of the recipient was much smaller. So I felt that I don't know what the legal environment is in Turkey. Brain death is a very difficult cultural barrier to overcome. I know that from being a Korean. But circulatory death is a widely accepted definition of death. And whether there's a room for DCD to take place in Turkey or not, I don't have the legal expertise, but I think this is something you should be aware that there's a viable path for DCD organs to be useful. So that's NRP. What is NMP, normothermic machine perfusion? The number one difference is this is X-side 2. So NRP, the liver is still in the donor's body, it's circulated. Now NMP is the liver is taken out, but then there is a circulatory support. So the goal is to resuscitate and preserve the organ. And typically DCD, but our surgeons use it also for DBD instead of cold storage. It reduces ischemic injury to the organ and improve early allograft dysfunction and graft survival. So this is a diagram. So this is the reservoir that has the basically blood and everything else that the organ needs. And the pump goes through gas exchange, it gets oxygen, and it gets warmed and gets fed into portal vein and hepatic artery, and then it perfuses the organ, and then it comes back to reservoir. This is when the organ is taken out with flushed on the left side, yellowish orange organ. Normally, that's the way the organ is transported to the recipient. But once you hook up the machine to NMP, that's what you see on the right side. And that can be preserved for many, many, many hours. You can easily imagine that organ in the recipient will work much better, much quicker than trying to wake up this yellowish organ. So this is actually a video, but I'm going to skip it. The result of NMP here is DBD, NMP, DVD's cold solution. No difference in the instance of early graft dysfunction. But if you look at the DCD NMP versus DCD cold storage, there's significant advantage of using NMP in DCDs. The right side is total operating time. The surgery is much easier. You can imagine that the red, juicy organ working much quicker, and the surgery is easier than cold storage. Graft survival is better. So the lowest is DCD cold storage. The second bad is DBD cold storage. And the top two lines are NMP organs. Rehospitalization lower once they are in the machine. So this is our own result. And it's a little bit crazy how much machine is used. So we were doing pretty well, and our volume was growing. 2018, 19, 20, 21, we were doing 200 cases, about half DBD, about half DCD. And then 22 NMP kicked in, and the data in 25 is incomplete. The actual number that we did was 321 cases last year. And 90% of our organs are pumped, and all of DCD organs are pumped. So by introducing these innovations, we're doing 50% more transplants than before, helping as many patients with the innovation. But there's always downside. There are two competition machines. The one that we use often is the one on the right side. And as you could guess, it's expensive. So OrganOx machine up to $50,000 and OCS machines up to $100,000. This is per patient. Per patient, per use. So that's an obstacle, but hopefully the price will come down and there will be further innovations. So I'm trying to get caught up on time. So then we're going to switch to MEL 3.0. I need to answer Dr. Golem's abstract review. So which of the following is in the MEL 3.0 equation? The answer is sex. Female sex is in 3.0. And the reason why that was needed is that when MELD was first started, before MELD was implemented in 2002, if you compare the blue bars and red bars, and this is comparing Black Americans versus white Americans, Black Americans had 50% higher chance of death than white Americans. With MELD, that equalized. Conversely, transplant chance was 25% lower if you're Black. That equalized with MELD. And that is related to the fact that Black patients were disadvantaged in terms of getting onto the list as soon as possible so that they have a longer waiting time. MELD got rid of waiting time, and everybody who's sick got transplanted, so that became okay. But MELD also created sex disparity. So before MELD, women and men were the same on the right side. With MELD, women died 30% more often than men on the waiting list. Transplant chance was 20% lower before MELD. It got worse to 30% lower chance for women. So this needs to be fixed. So that's why MELD 3.0 was done, to reflect the, fix the sex disparity, but also this was 20 years after the original MELD score, so that the epidemiology changed, the liver disease changed, we wanted to update everything. So that's the equation you can see there. So this is a paper that we are trying to get published in a high impact journal. We had whole year's worth of data post 3.0, which is on the right side. The left side is exactly a year's worth of data pre 3.0. If you look at the impact of 3.0 on mortality, it does what it was designed to do. So before 3.0, women died much more frequently than men. Post 3.0, the line is on top of each other. So the abstract that Dr. Golem showed argued that the transplant rate is lower in women than men, but that's not the metric. The metric that we're held by is medical urgency and risk of death. And MELD 3.0 equalized the risk of death. So that's the mission accomplished. It is also true that if you look at the transplant rate, 3.0, men got a lot more transplant. Post 3.0, the gap narrowed, but the gap still exists. And that's the body size difference. So looking into that a bit more closely, again, this is, you look at the multivariate analysis, risk of death. Before 3.0, women had 43% chance higher risk of mortality. After MELD 3.0, it equalized. For transplant, 0.78, meaning 22% lower chance of getting a transplant. It got better, but it's not quite at 1. It's still 10% difference between women and men. So how about body size? The smaller the body size, the more difficult to get the suitable organ. So most women belong in the lowest height group. Before 3.0, they were dying a lot more. That got corrected, so we talked about that already. In the shorter group, the transplant rate was much lower at 0.7. It seemed to have improved. But if you look at the shorter group in general, they are still a disadvantage, about 10% lower. Middle and taller group, the women are fewer, and it's hard to make a uniform conclusion about their transplant rate. But as the data are seen this way, the difference is much smaller in the newer era. So my summary is that perfusion technology has really revolutionized the practice of liver transplant, NRP improves utilization and outcome of DCD organs. NNP improves quality of organs for both DCD and DBD organs. Higher organ availability, reduced waiting time, and lower meld at transplant is what happened. We used to do transplants in the 35, 40 meld range. At our program, sometimes we can go into teens with higher organ availability, depending on the blood type. So transplant has become a lot easier. Patients are suffering much less with end-stage complications. Availability and costs are constraints of the machine. So my question to you all is there a future for DCD in Turkey? MEL 3.0 eliminated mortality disadvantage of women. Body size remains a constraint, and we still need to work on it. Thank you very much for your attention.
Thank you, Professor Kim. So, before the cases, we would like to take a few questions from the floor or comments, if there is. Murat?
I would like to answer the last question. So the DCD will be viewed as euthanasia. So the answer is no, it's impossible. And in a country where even brain death is not well understood and not well accepted by the people, it's impossible for them to convince them to take the ventilation off from their patients while they have heartbeat. So the answer is no.
Murat?
I appreciate that.
My
But the
my
determination needs to occur, I mean, right? So the decision to withdraw life support should occur independent of this decision, right? It's not, there is a strict conflict of interest protection that the transplant team is nowhere near in that decision, right? That the decision needs to occur independently. But I take your point. I'm not arguing that there is a concern for that.
Murat?
my question is to Jessica. My question is about the differential diagnosis, alcoholic hepatitis and alcoholic cirrhosis. How can we distinguish between alcoholic hepatitis and alcoholic cirrhosis?
I mean, functionally, it can be a little challenging, I'll be honest. They often, ACLF in someone who has chronic liver disease, who has cirrhosis, that is precipitated by alcohol use, often looks very similar to acute alcoholic hepatitis. And quite frankly, as we showed earlier, the vast majority of these people, 85 to 90% of them, will have cirrhosis. So even though the debate has been around acute alcoholic hepatitis, and that's a lot of what we talk about, functionally, everything that I talked about applies to patients who have decompensated alcohol-related liver disease and are presenting with high MELD and recent drinking. So we apply all of that at my center to basically any patient with ALD who comes in or presents for eval with recent drinking. We don't distinguish between those two things. From a surgical standpoint, as I understand it, the surgery can be very different for somebody who has a very big swollen liver from acute alcoholic hepatitis, et cetera. But even in the Accelerate cohort, which I talked about earlier, that they looked at the explants on all of these patients that had been assigned the diagnosis of alcoholic hepatitis, alcohol-associated hepatitis, and a substantial percentage of them, like 20 to 30%, had bland cirrhosis with minimal to no inflammation, right? Like the actual histology of the explant did not show acute alcohol-associated hepatitis, even though clinically it totally looked like it. And so I think it's, for the purposes of the psychosocial assessment, which is a lot of where this debate is, I'm hard-pressed to figure out why these features that we just discussed wouldn't also apply to just a decompensated, alcohol cirrhosis patient who presents with recent drinking. So we just kind of apply it that way in our center.
Thank you.
Great question. Thank you.
So we have recently finished and our national multi-center study on MEL 3.0, and it was accepted for publication in liver transplantation, and I think Dr. Kenan Mural will have some comments on our study.
Thank you very much for those excellent presentations. I have a question regarding the MALT3. In our study, which Professor Kabacham has mentioned, we found no difference between MALT3 and MALT sodium. We have, of course, a majority of living liver donor transplantation setting. And also in the superb analysis, interestingly, MALT sodium was very much more, had a higher area under ROC predictive performance for hepatitis B than in muzzled patients. So there was also this study, I think from Goldberg, where the predictive performance of the MALT system is decreasing due to the change in the etiology of liver. So should we actually, how will muzzled affect the overall performance of MALT itself, or should we put new variables inside besides sex or female variables?
Yeah, thank you. So I think MEL 3.0 is a point where how you use MEL score may diverge. So MELD was not developed as a replacement of Child-Pugh score for clinical practice. It was made to specifically to allocate organs without subjective elements, right? So when we refit the model, the variable of sex, whether when you look at a patient with a liver failure, female sex is that important for you to assess the patient's illness. It's not as important when you, in your clinical decision making, as opposed to organ allocation. So in my mind, 3.0 is not sort of, we're not going down the path as we go to 3.0, 4.0, whatever it may be. It may not necessarily be the measure of liver sickness. It may deviate more towards what's needed for organ allocation. So that's my answer number one, that you don't necessarily need to, we don't necessarily need to show that 3.0 works for all the situations. The important thing is it fixed the gender disparity, right? So even if the area under the curve is the same, if it addresses the sex disparity, it served the purpose. So that's where the divergence. We fixed the creatinine threshold, or the ceiling, and a few things because of the physiological changes that are seen in patients with more MASL versus Hep C, for example, that was from previous era. So in my mind, the model should work better for MASL than Hep C. There are so few Hep B patients in the US, I cannot anticipate how in that specific group it would work better or less. But I guess the bottom line is we're not, MEL 3.0 was not conceived as a universal, like the best of all MEL score. It had a specific purpose of addressing the disparity.
So I'd like to ask one final question to Professor Golam. Are you waiting for the studies, or are you using the checkpoint inhibitor plus local regional treatment combinations for neoadjuvant basis?
Right. So there are already some data in the neoadjuvant space, primarily for the combination of TACE, just traditional TACE, DEP-TACE, with the combination of durvalumab and bevacizumab. This set of data suggests that there is a progression-free survival benefit in that group of patients. We don't use this routinely, and it is challenging to actually get patients approved for both durvalumab, a fairly expensive medication, and also apply local regional therapy. I should also say that in the United States, local regional therapy these days means TARE, not TACE. TACE is a species on the verge of extinction. There's very little TACE going around. So you would have to extrapolate that your outcomes are similar with TACE than they are with TARE than they are with TACE. So to answer your question, we don't do this routinely. We certainly don't do it in the pre-transplant setting for downstaging. But I know there are some places that selectively do.
Cases.
In the case-based panel discussion, firstly, I invite Murat Harputluoğlu.
Dear chairs, dear colleagues, I would like to begin thank you very much, organizing committee and ASLD faculty members, and especially Professor Idelman. My case presentation, 71 years old male patient. He had 17 years ago living donor liver transplantation for hepatitis B, hepatitis D, and hepatocellular carcinoma. Before 1 month ago, transplantation, November 29, AFP level 5.3, HPV DNA negative, HDV RNA unknown, anti-delta positive, and 5 and 3 centimeter ACC lesions and multiple dysplastic nodules in the liver. Postoperative first month, hepatitis B immunoglobulin were given, and antiviral treatment, tenofovir, was started. But 12 months later, 2010, S antigen was positive. HBV DNA 19 million copies, ALT 50 units. And my first question, what is the next? What do you recommend in this situation?
For the sake of time, let's skip the questions and
Okay.
come to the
Okay.
end, then we
Okay.
will discuss.
Okay. We stopped hepatitis B immunoglobulin treatment. Tenofovir treatment was continued. Postoperative 30 months, HPV DNA 4,000 copies, and also HDV RNA was positive, 45 copies. ALT slightly increased, 105. Total bilirubin, INR, and AFP were low, normal. It's the next. And, excuse me, tenofovir treatment was continued. Postoperative 4 years, HPV DNA negative, HDV RNA 200 copies, positive, ALT 89, total bilirubin and AFP normal, TDF treatment continued. 10 years, HDV RNA very high, nearly 2 million copies. HPV DNA negative, albumin slightly decrease, 3, ALT 71, total bilirubin normal, INR 1.3, AFP slightly increase, 26, TDF continue, liver CT show no ACC recurrence. And we did liver biopsy, chronic hepatitis and fibrosis for
I have a
any
question,
discussion?
Dr.
Please.
Philip. Is there any specific treatment? Pierre, sorry,
Pierre.
Pierre, sorry. Is there any specific treatment for hepatitis delta virus of recurrence after liver transplantation?
Mikrofonu alabilir miyiz?
So there are proposed and established treatments for Delta already. These are mostly been studied in the pre-transplant or non-transplant state. The one most widely available is bulevirtide, which is approved in the EU, but I understand is not available in Turkey, at least not easily available. And then there is a combination of siRNA molecules along with antivirals that are being studied that are actually probably 2 to 3 years away from regulatory approval in the US. Historically, though, we would give these patients interferon, which I'm sure you do in Turkey too. I found this to be an incredibly unfruitful avenue for a long time. The NIH, Theo Heller and the NIH had a study over 10 years that looked at this and showed some reduction in viral load, but probably not great impact on outcomes. And there are prenylation inhibitors, which is a class of drugs that seem to suppress viral load, but they have very prohibitive GI side effects, which make them not the most palatable. I'm just curious, what happened to this patient? Why did they have this dramatic bump in their delta? Are they not taking their medicine from time to time, or?
We could not do anything. Interferon may increase the rejection risk.
No, the question is what happened as a cause of this relapse?
It looks like you did everything
now I
right.
will say that.
I'm saying it looks like you did everything right. You gave the patient HPIG, you started them on antiviral therapy, and from the get-go, about 3 months later, their delta viral load was 19 million. So I'm just wondering what happened to that patient that caused this to flare up so much.
Yes, the ALT level is good, liver function is good. No problem. We didn't see anything in liver function, and the patient is well. We didn't see any big liver problem.
Delta hepatit neden nüksetti ilk başta? Soru o abi.
Let me kindly remind that in Turkey, reimbursement issue is that HB treatment for a long time for the patient with delta hepatitis. There is no doubt that probably this patient did not come to visit to take his HB treatment. Yeah, in that situation, the past 10 years after liver transplantation,
29.
Okay, I think it's past 10 years after liver transplantation. I would like to try the PIC interferon treatment for this patient, even there is a risk of the rejection. Because just try 3 months. If everything is going well, I would like to continue 1 year. Yes. Because already passed more than 10 years for this patient. So there is no alternative treatment.
And the patient is deteriorating the liver function, the albumin coming down to 3, maybe the cirrhosis will come soon. So, of course...
Later albumin is good.
Yeah, so
no problem.
The best option here is bulevirtide, as you have mentioned. I have few patients, of course not after transplant, but compensated cirrhotic patients. All of them went fairly good and all had virologic response, but it's a very expensive treatment and it's very difficult to find and use in the Turkish
and also
patients.
Maybe ACC can contribute to HPV recurrence.
Yeah, but there is no HCC recurrence here, right?
No.
Theoretically.
I don't mean the ACC recurrence. Maybe previous ACC history can contribute to HPV recurrence.
Yeah, just to be clear, bulevirtide is not approved in the U.S. either. It is about 2 years ago. It was thought that it might be approved, and then the FDA sent the sponsor a complete response letter saying that they don't feel that the manufacturing of bulevirtide is up to par. And bulevirtide, unlike almost every drug we use in GI and hepatology, does not come in an auto filler pen, in an auto injection pen. It actually comes in a glass ampoule that you have to break and suck the medicine out and then inject it yourself, which I can tell you American patients will never do. I can guarantee you that. So there are some challenges related to administration, which will likely be a problem.
Okay, let's continue.
And 13 years after the transplant, HPV DNA negative, HPV RNA 292, ALT normal, liver function is very good, INR 1.2, AFP 6, no ACC recurrence. And you can see HPV DNA, HPV RNA levels and ALT levels. Summary, liver transplantation for HPV DNA, hepatitis D, ACC. In the 1 year, HPV recurrence. In the 30 months, HPV recurrence. No ACC recurrence. And liver function is very good. I would like to present the interesting hepatitis D case.
So the delta recurrence behaves very weirdly after the transplantation. I have a case that was recurred like a few months ago after the transplantation, and she got cirrhotic, decompensated, but then the disease paused. There was no further decompensation events. It's very easily treatable with simple measures, and there was no chance for retransplant. So we are now following her. She's now in 8 post-transplant years with cirrhosis.
Okay. I have a little contribution. In normal, we wait the HCC recurrence after liver transplantation if we have a HBV recurrence. But in that case, in spite of behind Milan criteria HCC patients, but we did not see HCC recurrence. Probably the AFP level was very, very important, the very low level.
Okay, thank you for your nice case. And let's skip to the next presentation. Dr. Elvan Işık from Ege University, İzmir, will present another interesting case. We have short time, so let's leave the questions to the end.
Okay. Good afternoon, everyone. I would like to thank the organizing committee for this excellent meeting. I'm Elvan Işık from Ege University, and I have no disclosure. The case I will present is 44 years old male patient. He's married, father of 2 children, and he is a teacher. His medical history includes IgA nephropathy, diagnosed with biopsy in 2015, diabetes in 2016, and he was diagnosed with cryptogenic cirrhosis 7 months ago. His medication includes diuretics, propranolol, ramipril, and basal insulin. He has no surgical history. He is an ex-smoker, no alcohol and substance use, and his family history was unremarkable. On March 2024, he was referred from another hospital to our Institute for Liver Transplantation due to decompensated liver cirrhosis. He's looking at his medical history, as I mentioned before, he was diagnosed with IgA nephropathy, and he was started on ACE inhibitor, and he received oral prednisolone for 6 months at that time. In June 2023, due to increasing creatinine and proteinuria, He received a high dose of pulse methylprednisolone for 3 days. Subsequently, he developed ascites, pretibial edema, and on abdominal ultrasound, it showed cirrhotic findings and diffuse ascites. The investigation of etiology did not reveal any cause, and so he was diagnosed with cryptogenic liver cirrhosis. He had no history of hepatic encephalopathy and no variceal bleeding. He required intermittent large volume paracentesis for tense ascites and was hospitalized twice for spontaneous bacterial peritonitis. At presentation, his chief complaints were abdominal distension with diffuse ascites, bilateral pretibial edema, and fatigue. On physical examination, he was conscious, vital signs were normal, he was afebrile. Distension, abdomen with diffuse ascites and splenomegaly was presented. Respiratory and cardiovascular examinations were all normal. Initially, laboratory tests showed slightly elevated ALP, GGT, and bilirubin levels. Albumin level was a bit low. He had pancytopenia. INR was 1.4. Creatinine was 2.2 milligram per deciliter. Transabdominal ultrasound showed features consistent with cirrhosis, splenomegaly, and diffuse ascites. So in the investigation for etiology, we couldn't find a cause either, and his serum ascites albumin gradient was 1.6, consistent with portal hypertension, and there was no SPP on acidic fluid analysis. We performed abdominal MRI. It was similar with ultrasound findings. There was no evidence of HCC. Upper GI endoscopy revealed esophageal varices with portal gastropathy. On his clinical course, on the follow-up, his renal functions deteriorated and his creatinine increased up to 4.7. The urine sodium was below 20 millimole, and he was diagnosed with hepatorenal syndrome. And appropriate treatment initiated with human albumin and terlipressin, and on the follow-up, his creatinine improved to 3.1, and his daily urine output was adequate. At that time, his MELT sodium score was 26, and child score was 9 points. We evaluated this patient with the liver transplant committee, and we recommended the patient for a liver transplantation, and his wife became a donor candidate. We especially discussed this patient with nephrology to assess if there is an indication for simultaneous kidney transplantation, and they concluded that he is non-oliguric and he doesn't require any renal replacement therapy, so kidney transplantation is not indicated at that point. After the preparations, the patient underwent living donor liver transplantation on March 29, and explant pathology was reported as cryptogenic cirrhosis. No specific etiology was identified. We started postoperative immunosuppression according to our institute protocol with methylprednisolone. We preferred basiliximab due to renal dysfunction at early time, and we started tacrolimus a bit late on day 5 and MMF on day 4. Postoperative portal Doppler ultrasound revealed all vascular structures were patent, and there was no pathology on the Doppler ultrasound. On April 12, he was discharged with no complication, and his laboratory tests were stable. Creatinine was 2.1, and his immunosuppressive treatment, prophylactic therapy, and treatment for nephropathy was continued. On the first week outpatient follow-up, everything was normal. He had no complaints, and he was clinically and laboratory stable. On the second week, he had minimal abdominal distension, but vital signs were normal. There was no fever, and the other physical examinations were normal too. On the laboratory findings, liver functional tests and renal functional tests were similar with baseline. There was slightly elevated CRP, and abdominal ultrasound showed mild abdominal ascites, but there was no evidence of SBP. And further evaluation for the other infection focus was all normal with urinalysis and chest X-ray. So we increased furosemide dose and follow up closely this patient. 2 weeks later, after 6 weeks from the transplantation, he presented to emergency department with worsening abdominal distension, abdominal pain, and there was some systemic symptoms like nausea and loss of appetite. On physical examination, there was markedly abdominal distension with diffuse ascites, minimal erythema at the surgical incision site, but he was still afebrile and vital signs were normal. At laboratory tests, renal function and liver function tests were still stable, but CRP was elevated to 124. However, procalcitonin was normal, and anemia had worsened with hemoglobin levels 8.2. The other tests, complete urinalysis and chest X-ray were normal. Abdominal ultrasound performed in emergency department showed normal transplanted liver with minimal organized hematoma, but there was diffuse ascites with occasional septations. So we hospitalized the patient, and on the acidic fluid analysis, there was no SBP with predominance of red blood cells. The serum ascites albumin gradient was below 1.1, and the other parameters like bilirubin, amylase were all normal. There was no growth in the cultures, aerobic and anaerobic cultures, mycological cultures, and mycobacteriological studies were all negative, and cytology was reported as benign twice. After that, of course, there is a de novo ascites. We performed portal Doppler ultrasound. And in the ultrasound, all vascular structures were patent with no thrombosis or significant stenosis, and there was still diffuse ascites containing occasional septations. We consulted the patient with nephrology for these ascites, and they concluded that his creatinine is 1.8. He has mild proteinuria, no hematuria, and no active urinary sediment. So current ascites cannot be attributed to renal dysfunction. We performed echocardiography, and it was normal, so cardiology excluded cardiac etiologies. And substantially, we performed abdominal CT, and as you can see on the images, it showed encapsulated, septated intra-abdominal collections, peritoneal thickening, displacement and clustering of small bowels, and transplanted liver was normal. So all these findings was reported as cocoon-like encapsulating sclerotic peritonitis. Actually, it's a very rare clinical condition with only a few case reports, so it was surprising for us. At that time, the patient's appearance showed mildly abdominal distension, and he appeared cachectic due to poor oral intake. By the way, informed consent was obtained from the patient. He shared his photos himself with me. So what did we do? We continued to the immunosuppressive therapy, and appropriate nutritional support was provided with the guidance of a dietitian. And bilateral ascites drainage catheter was attempted by interventional radiology. But as expected, it failed because of the septations. So we discussed the patient with surgeons at a multidisciplinary meeting, and surgery was decided for this patient. On June 14, he underwent the operation, and operative note reported a thick 2 centimeter in diameter fibrous capsule covering the whole entire abdomen, peritonitis findings with a honeycombing appearance separated by septa. The capsule was opened and a large amount of ascites was drained. The peritoneal capsule was drained, and lastly, the intra-abdominal washing was performed. Here you can see the thickened peritoneal capsule, the peritoneum, and this is the drain replaced by radiology and the drainage of ascites. Sorry. The macroscopic view of parietal peritoneum you can see on the left side, and histopathological findings revealed fibrovascular proliferation in parietal peritoneum, inflammation and fibrin exudation, and there was no epithelial or mesothelial proliferation, so we could exclude the malignancy. After the operation, everything went well. The distension resolved and oral intake improved. And I saw the patient last week in the outpatient clinic. He had no complaints. His physical examination were all normal. Laboratory tests were stable. His creatinine was 1.7, and abdominal ultrasound showed no free fluid in the abdomen, and transplanted liver was normal. And he continues regular follow-up by the organ transplantation and nephrology outpatient clinic. And this is the photo of the last week. Thank you very much.
Thank you for this very comprehensive case presentation. I think there is no room for questions or comments, as we have done everything. And to save some time, let's go to the coffee break for 15 minutes and then come back for the last session of viral hepatitis. Thank you.